So, good morning. We're just about ready to start. We're just loading one last presentation because somebody doesn't follow directions and get them here early. So, oh, look at that. Great. If anybody wants to move forward, that'd be great too. We'd love to, because we're going to have a conversation here at the end. So, welcome and good morning. Very glad you're here on the third day of the conference and at 8:30. You're the hardy folks in global health. So this morning we're going to have, I think, an exquisite panel for you, presentation of some of the leaders in global health, specifically focusing on ending violence against women and girls. So this plenary is violence against women, looking back and moving forward. We have 4 presentations. Each presentation will be about 15 minutes, and we'd like to leave the half hour to have a discussion with you and answer questions and really dialogue about how we're moving forward with violence prevention and ending violence against women globally. So I'm going to introduce our panel, and they'll come up. So I'll do an overall introduction for you. And just to let you know, I'm Nancy Glass. I'm a professor at Johns Hopkins University School of Nursing and the Associate Director of the Hopkins Center for Global Health. So first, let me introduce Dr. Lori Heisey. Dr. Heisey is a professor. Congratulations. 2 weeks ago, she was promoted. Yay. We love to see that. Professor at the London School of Hygiene and Public Health in England, and we have done the good thing of recruiting her back to the United States, and we'll be starting at Hopkins as a joint appointment at the School of Public Health and School of Nursing, starting in September. So we're really excited about that. And Lori has been in violence against women and prevention of HIV for, I don't want to date her, but 40 years. So since she was 15. So we're really glad to have her here. And beside her is an amazing colleague. I just had a chance to go out to see her work in Arizona. This is Dr. Krista Johnson Agbakwa, who is the founder and director of the Women's Refugee Health Center in Maricopa County in Arizona. And she is an expert. She's a physician, OBGYN, and really has built the evidence and work on serving women with female genital cutting, and now has been doing amazing work in women's health. So just quickly about Krista, her services oftentimes receive refugee women who've had the most complicated cases. And she's been working with survivors from the Democratic Republic of Congo. And so she asked if she could come and visit DRC, where I've been working, so she would have a better understanding of what the women she's serving have faced. And I just think that's an amazing compliment to her and her understanding of the complexity of women's issues coming from diverse countries. And beside her is Dr. Anna Baptiste, who came all the way from Mozambique to be with us today. She is directing, she's at JPIGO, which is an affiliate of Johns Hopkins, and directing the gender-based violence prevention programming in that country. And then my colleague at the end is Dr. Carmen Alvarez, who is an assistant professor and nurse practitioner, nurse midwife at Johns Hopkins School of Nursing, and is doing amazing work with immigrant women, Latino women here in the United States. So I think we have a wonderful program for you. So let me welcome Dr. Heisey to the stage, or to the podium.
Well, I thank you all for being so intrepid to be out here at 8:30 in the morning on a Sunday. I was asked by the organizers just to give sort of a brief, really quick overview to set the stage for the great work that my colleagues here are doing. I'm going to be drawing a lot on some of the work I've done over the last period of time on intimate partner violence, and sort of just giving you the high points of some of what we've learned more recently through research-based approaches. So what do we actually know about the larger field of gender-based violence? One of the things that we know and has been sustained through research throughout the world is that intimate partner violence or violence within relationships is actually the #1 form of violence that women face. And that's true even in conflict situations. So even in areas where women are suffering terrible sexual violence and coercion and things in the context of war, if you actually go into camps and you do surveys, the dominant burden that those women are still facing is violence within their relationships. We also know from a lot of research that has been done around the world that the health consequences are profound, and that injury, which is what people used to focus on, is actually probably the least important consequence of violence, and that actually we should be considering violence more as a risk factor for long-term health sequelae, and that the impact of that is cumulative over time. The other thing that is really clear is that the types of violence in women's lives overlap, both in terms of individual relationships and also within the life course. And so one of the things that we're trying to get people to do now is, rather than studying specific types of violence, like sexual violence or child sexual abuse, is to talk about the life burden of violence, because one of the things that we know is the impact is cumulative, and if you've experienced something earlier in the life course, your risk of having repeat events is higher throughout your life. And so we really need to be understanding not just what has happened to a woman in one moment in time, but what is the burden that she's bringing with her into that context. So this is just to give you a real quick overview of what has been documented in terms of the health consequences of violence. And this is a slide that we used when we were doing the global burden of disease exercise that was done out of my center. We were looking at what portion of the global burden of disease could be attributed to different risk factors, and we did the one on intimate partner violence and child sexual abuse. And as part of that, we did large systematic reviews of a whole range of different health outcomes. And so briefly, in terms of injury, what you see is, and these are global averages, so, I mean, they can only tell you so much, but 42% of women globally who experience intimate partner violence have an injury at some point during their lifetime. They're twice as likely to have depression. In terms of substance abuse, they're almost twice as likely to have some sort of alcohol use disorder. And then in terms of suicide, they're 4.5 times more likely to attempt suicide. And some of what you see in the terms of health consequences is that it's not direct, but it's the fear and control that is part of the relationship that then affects what women are able to do in terms of reproductive and sexual health. So for example, they're 16% more likely to have a low birth weight infant, and that translates into higher morbidity and mortality for their children. And they're 1.5 times more likely in longitudinal studies to acquire HIV. So that just gives you a real quick overview of the range of sequelae that women face. Now, the other message that I want to give today is that we've come an incredibly long way in demonstrating that we actually can reduce intimate partner violence in these low and middle income country settings within project relevant timeframes. So there's been 9 randomized controlled trials, community randomized controlled trials now, where we have been able to successfully demonstrate reductions, and some of those reductions from a public health standpoint are quite significant. So here, for example, is a program from Uganda. It's a community mobilization approach to promoting shared power between partners, and demonstrated a 52% reduction in incidence of IPV over 3 years. There's also been work, for example, in the Kibera slum in Kenya, where they've trained through a combination of self-defense and girls' empowerment to be able to reduce the rate of rape or sexual assault against these young girls by 62% over, it was actually a 10.5-month time frame. There's also been some really interesting results in the context of studying cash transfers or social protection programs. And here we see that in some settings and contexts, especially those of very poor families, just the provision of cash alone is reducing conflict and intimate partner violence. So here was a program that some of you may be familiar with in Kenya called Give Directly, where they give actual just funding to families, transfers, and showed a 30 to 50% reduction in reports of physical IPV and 50 to 60% of sexual IPV within marriage just by the provision of that cash alone. And we've done some work to try to understand what is the mechanism there, and so far, and we're still exploring this, but it seems to be that in very poor settings where women have to negotiate every day for the audio or the money to go out and buy food for the day, that is a real flashpoint in terms of conflict. And so just eliminating that, and that she has a little bit of cash so that she can provide daily for the family seems to be one of the mechanisms that this cash is influencing IPV. One of the things that I think is really important when we think about primary prevention programs is what is the mental model we have in our head in terms of how we think about causality. And coming from the women's movement, we have found ourselves in many different arguments over, is alcohol part and parcel of the cause of domestic violence, or is something else? And I think that comes from trying to apply a mental model that's sort of an infectious disease model that says X causes Y. And really, when I talk to my students, what we're trying to do is we need to be thinking of this much more like heart disease, where it's a probabilistic outcome, where things interact at different levels of the social ecology and increase the likelihood that there will be violent events. So one of the things that we use is an ecological model where we talk about the fact that you have a man who comes to a relationship, he has his genetic endowment, he has his whole developmental history, what happened to him as a child, was he parented well, was he abused as a child, you have his current beliefs and behaviors. That is together with the woman who also brings all of that history and that genetic endowment to the relationship. The relationship itself has individual dynamics, and you see that poor communication and lack of relationship skills increases the risk of partner violence in these settings. That obviously is embedded within a community with certain norms and within larger macro structures which infuse all those different layers. So one of the things I think is important and is forgotten when we use these kind of campaign slogans, which are actually based on fact, that 1 in 3 women, for example, will be a victim of physical or sexual violence in their lifetime. That is a number from the Global Burden of Disease exercise. But what it leaves you with is a sense that everyone is equally at risk. And actually, that's not true. What we see is this is data from the WHO multi-country study on domestic violence. And each of those, if you can't see them, it's just one of 10 different sites that this study was done. And you see vastly different rates at a country level. So in Yokohama, Japan, and in Serbia, in Belgrade, you have about 3.7% of women who in the last 12 months have been a victim of domestic violence. And that's actually very similar to the rate that you see in the US or the UK or Canada. Compare that to an order of magnitude difference in places like rural Ethiopia or rural Bangladesh or rural Peru, where you have 40 to 50% of women who report being beaten within the last 12 months. Now, I think on top of that, it's very important to recognize that there's as big differences within countries as there are between countries. So it's not just that some countries have lower levels and some countries have higher, but actually at every single level, where if you go down, you'll see regional variation that is as profound. If you go into, for example, a city and you go by neighborhood, you will also see the same level of distribution of high versus low. So I'll show you this. This is data from Brazil, from the multi-country study, and the purple bars there are from São Paulo, so the capital. And what that shows is the proportion of the clusters. So if you think of this was a cluster design trial. So it's not a trial, excuse me, cluster survey. If you think of it as at the left-hand side, yeah, your left-hand side is the proportion of clusters where none of the women were beaten in the last 12 months. So that's like 6.5%. All the way up to, on the very far right, 70% of the women beaten in the last 12 months. And what you see is actually quite a nice, almost normal curve there. If you go out to rural parts of Brazil, to Pernambuco province, what you see is a similar distribution, but it's shifted to the right? So the mean is higher, but you still see a huge distribution. And so what a lot of my research has been is to try to understand what is behind this distribution and what can we learn in terms of prevention. So the kind of motivating force of my research is what accounts for these differences. And we've done a lot of work in that, but one I'll just share briefly today. One study where we were just doing very simple ecological analysis of trying to look at, explore sort of higher order factors in the ecological model and say, is there a relationship between X factor and the population level of violence? Not individual, does it increase in individual women's risk, but how do these factors relate to the overall levels of violence? And so what we did is, one of the things I wanted to do is actually test the sort of feminist assumption or that gender, either gender inequality or women's status, was very much related to levels of violence. And so what we did is we looked at a variety of different factors in terms of women's achieved status, levels of gender inequality, various norms like the acceptability of violence, aggregated again at these higher levels. Minutes? Great, thanks. Aggregated at higher levels and looked at, for example, does the level of the acceptability of violence, for example, relate to the level of violence? Does the level of women's education at a population level correlate to the level of violence in that population? We also looked at things like economic and social rights. So looking at that, and you don't have to really look at that chart there, but the bottom line is everything goes in the direction that you would expect if indeed women's achieved status and gender inequality were related to the overall levels of violence. And if you pick out in terms of what seems to be driving things at different levels is the norms, the things that are our surrogate really for norms. So the acceptability of partner violence and the level of male authority over women's behavior are very strong factors that are tightly correlated to levels of domestic violence. Also, gender discrimination and property rights, so land is the strongest of the things we looked at in terms of the gender inequality domain, and then also inheritance and family law. So for me, what's interesting about that is, and that has to do with whether or not there's discrimination in terms of, for example, women's ability to leave, either in terms of divorce or maintain custody of children or inherit post-relationship. And what we see is that actually that's a stronger factor than even the criminalization of violence in the law. And so it sort of focuses our attention potentially in a new direction. One last thing that I want to leave you with is just an insight that we're starting to do a lot more work on, which is that the same factor can operate differently at a population and an individual level. And I think it's really important for us to think about this, because what we know, for example, if you look across Africa, women who are employed or who work for cash in Africa are at higher risk of experiencing domestic violence. However, countries where a larger proportion of women are in the formal labor force have lower levels of violence. And what we think is happening there, and especially there's interaction between the level of acceptability of violence and some of these gender-related factors and women working. So I like to think about it that if women are sort of on the vanguard in their setting, and they are some of the women who are first entering the labor force, it is a risk factor for violence, because they're sort of breaking certain expectations and molds and potentially threatening the gender roles in that relationship. Over time, as more women enter, that same factor that used to be a risk factor becomes actually non-relevant. So in the US, whether you work or not has no influence on your risk of domestic violence. And also over time, as countries go through a transition where women start to work more and more, overall the levels of domestic violence go down. So we're starting to try to unpick what these different relationships are and how they interact in order to try to give us insights for prevention. And I think I'll stop there.
Good morning. It's truly an honor to be here with you, and I want to thank Dr. Nancy Glass for inviting me to be part of this distinguished panel. So today I'm going to talk about optimizing trauma-informed care for refugee women survivors of gender-based violence. As we all are aware, 1 in 3 women still experience physical or sexual violence. And specifically when we talk about refugees, refugee women are a particularly vulnerable population because not only are they dealing with the risk of experiences and trauma of war and forced displacement and exposure to exploitation and rape, but during their flight, whether in refugee camps or even in their country of first or second asylum, they still face risk and threats of ongoing exposure to violence. As we all are aware, we are currently facing a global refugee crisis that has never happened to this extent since World War II. Currently, 65.3 million people worldwide are forcibly displaced. The United States has played a historic and very strong role in being a major host nation for refugees. And as you can see, over the years, we've consistently resettled populations from all around the world, from 70 to 85,000 per year. And at the close of the Obama administration, Congress approved an increase to the ceiling of 110,000 refugees. However, in this current Trump administration, we're seeing dramatic threats to refugee resettlement in the US. Not only what we see with the recent travel bans and the attempt to halt refugee resettlement for 4 months, but also the fact that the ceiling has been lowered to 50,000, and that's currently under threat and severely affects the populations that we've been serving across the United States. And so what we know about internally displaced persons and refugee women in crisis, as you can see listed, there are a host of challenges and threats to women's health relating to sexual exploitation. You can see abandonment, involuntary recruitment into militia and armed forces as the wives of rebels, the extended time they often spend in refugee camps where they may have limited access to humanitarian aid, educational opportunities, and even the ability to participate in decisions directly affecting their lives. And there are specific challenges to gender, such as confusion over who is a woman at risk. There's inconsistency in the requirement and criteria for resettlement. Often staff are inadequately trained. There's a disregard of rape and sexual abuse as sufficient grounds for resettlement. And there's also a culture of distrust of refugee stories. There's also a disbelief in the extent of abuses women and girls face, and they often lack access to education, and resettlement opportunities and experience poor quality of physical care, social service access, and legal protections. And there's, as we are seeing, very slow response time among resettlement countries. However, post-resettlement, there are some immediate protection benefits in that women can be removed from abusive and exploitative situations, from hostile environments, and the hope of preventing future acts of violence, rape, kidnapping, and forced marriage. However, even post-resettlement, there remains ongoing threats to women's health, whether it's relating to their cultural adjustments and experience of trauma, linguistic and social isolation in their host country and resulting economic insecurity, and of course, community alienation due to shame and stigma, inaccessible services due to the language barriers and not understanding how to navigate the system, and fear of deportation. And so what we know is that violence against women is often underreported. In our current context, there's a reluctance to seek help from law enforcement, due to the history of human rights abuses by authorities in refugee camps, but also, as we're seeing currently, the fear of deportation, particularly in our current very anti-refugee and anti-immigrant rhetoric that is present within our nation. We also see victim blaming, stigma, and shame from within these communities, and religious values that stress forgiveness and maintaining traditional family structures. Often women have very limited English language proficiency and, as a result, limited access to services for sexual violence survivors. And there are very few resources on sexual and reproductive health and violence that are grounded in trauma-informed care. And so what we see is a trauma of silence about sexual violence, which leads to denial, non-reporting, hesitancy in seeking services. So we as healthcare providers must create a safe space for open dialogue where we can provide support for survivors, prevent future sexual violence, and facilitate survivors' journey to recovery and healing. And so in 2008, I founded the Refugee Women's Health Clinic in Phoenix, Arizona. Many of you may not be aware, but Arizona is one of the top 10 states for refugee resettlement. We have hosted over 82,000 refugees over the years. We get about 4,000 to 5,000 new arrivals every year. And within that context, the Refugee Women's Health Clinic has been able to serve women from over 49 countries across sub-Saharan Africa, Southeast Asia, and the Middle East. Our largest populations are from Somalia, Iraq, Democratic Republic of Congo, Burma, and we are responsive to the demographic shifts and trends with refugee resettlement coming to our state. And what is unique about our model is that we're the first clinic of its kind in the state of Arizona, and we have been nationally recognized as a best practice model for improving refugee women's health due to the unique application of services that incorporates cultural health navigators, as you see reflected in the picture. These are women who themselves are refugees with shared experience of displacement, shared language. They are trained, certified medical interpreters, but also they're the important cultural liaisons between the community, our refugee families, and the healthcare system. So we are a patient-centered and community-driven clinic. Our mission is to provide culturally and linguistically appropriate services to the refugee and immigrant women in Phoenix, and to reduce and eliminate health disparities and cultural barriers to care. Since we've started, we've served over 5,000 women and delivered close to 1,200 newborn babies, and have expanded our pediatric refugee program as a result. So we're anchored in 3 key values, in that we are locally accessible and globally minded, helping refugee women navigate the healthcare system and increase their health-seeking behavior. We seek to overcome barriers to care in providing culturally sensitive healthcare, and we also aim to empower women, enhancing their health literacy and eliminating the myths surrounding reproductive care, childbirth, and preventive services. We have an integrated care model of 5 C's that comprise cultural health navigation, communication to promote health, care coordination, community-partnered engagement, and capacity building. And within this framework, we've been able to create a safe and supportive network for refugee survivors of sexual and gender-based violence. that is anchored in trauma-informed care, cultural competency, in the training of providers and behavioral health specialists, women's empowerment programmatic activities, as well as community-based participatory research, where research and engagement is co-led and co-developed by the community. And we also seek to employ empirically supported treatments. One of the first partnerships that we engaged in was with the Office of Refugee Resettlement to create Congolese health videos. We have a growing number of Congolese refugees coming from the areas most affected by sexual violence, and we've been able to create a video series partnering both with women and men in the community to provide an introduction to the healthcare system, understanding about pregnancy, childbirth, and women's health and reproductive care. And men also participated, and there's a segment developed by the men where men speak about how they're helping their women heal. And then women also spoke in terms of how they are finding wellness after war. And so this video series is not only used within our state, but has now been nationally implemented through IRC, the International Rescue Committee, as part of their cultural orientation for Congolese refugees. And also through funding through the Patty Brisbane Foundation, we've been able to create a culturally informed educational program to promote sexual health and well-being among our refugee women. And this was an educational program tailored to Somali women affected by female genital cutting, as well as our Central African Congolese women who are survivors of gender-based violence. And through this curriculum, we were able to create a safe space for women to get together to learn about basic genital anatomy, healthy sexual response, basic elements of promoting sexual health and their well-being. We've also been partnering across the state with our Department of Health Services in promoting a statewide initiative to build capacity among providers, specifically behavioral health providers, in meeting the unique needs of refugee populations. And this is a strength-based, patient-centered approach where we've collaborated with our resettlement agencies and our refugee clinic, and we've been hosting a series of training exercises for behavioral health specialists, and it integrates community members as facilitators of these groups. And we've created support groups for women on gender-based violence as well as female genital cutting. We've had a validated screening tool that we've been implementing in our clinic, the Refugee Health Screener, that we've been able to showcase screens for PTSD, depression, and anxiety. And we've screened over 500 women, of which our Iraqi and Congolese women had the highest positive scores. And we have a strong system of referral to behavioral health, and through which we've been able to diagnose depression and PTSD in about 35% of these patients, of Iraqi and Congolese primarily. We are also fortunate to partner with Johns Hopkins, Dr. Jackie Campbell and Nancy Glass's group with a assessment of danger and safety and mental health and empowerment. And this is a two-phased project where we've been able to work with our Congolese women to identify risk factors for severe intimate partner violence and intimate partner homicide and protective factors. And this will be used in the second phase to assess the administration of a safety decision aid. And just some preliminary results of that, we found that among our Congolese refugees, when asked about their perception of danger, we found that there were individual and society level factors such as substance abuse, financial abuse, and threats of deportation. And then the societal level views in terms of their general lack of understanding of the US system, the impact of war, and forced marriage. There were some protective factors that women were able to elicit in terms of how they keep safe in their relationships. On the individual level, it was keeping quiet, complying, praying, having children, as you can see with the quotes on the left. And societal factors was awareness of US laws. And we also have some work in Burundi, Central Africa, and we've been working to build and understand some of the healthcare needs before, during, and after war in both the rural province as well as the capital, Bujumbura. And we've worked with 52 women who've been internally displaced and voluntary repatriates. And we were able to assess their health status and found that before the war, as we can imagine, there was good health, food availability, health issues relating to non-war related concerns. But during the war, as we are commonly see, exposure to disease, rape, lack of health services, unwanted pregnancy, and the need for medical services due to intimate partner violence. And so we're continuing our ongoing efforts returning this summer, and hopefully we aim to establish culturally and gender-specific interventions to improve their health status and seek to promote greater healthcare access and prevention. And finally, looking to the future, we're hoping to partner with Dr. Nancy Glass and the Center for Global Health at Johns Hopkins to implement a culturally sensitive, community-based approach to address the health and social impact of trauma and violence, and implement validated tools that Dr. Glass has used in humanitarian settings, in domestic U.S. settings, to help identify survivors, increase their safety planning, and reduce exposure to ongoing violence and abuse. And most importantly, link these refugees to much-needed medical, behavioral, and social services. And ultimately, we aim to improve their clinical and social outcomes. So in closing, it's very important as we think about how we can enhance refugee women's health care that we address the ongoing concerns around sexually transmitted infections, contraception, unplanned pregnancy, promote their sexual and social well-being, reduce the stigma and shame at the community and family level, and prevent future acts of violence. But when we think about the healthcare setting and healthcare context, building trust is paramount. And looking at how we provide care. Can we provide gender concordance, appropriate language interpretation, audiovisual aids to address the limited literacy, and promote greater provider cultural competency and training, and ensure access to care by addressing the structural barriers to care. And so when we think about future directives, it's important as we consider how we can optimize trauma-informed care that we recognize that refugee women possess extraordinary strength and resiliency. It's easy to look about the challenges and the exploitation and the vulnerabilities, but there is extraordinary strength that we can harness and the cultural values that they bring that we can use to inform our work. Furthermore, we need to provide quality reproductive and sexual health care and anchor this in community-based and partnered research that is co-led and co-developed and informed by the community, seek to promote women's empowerment by enhancing their health literacy and supporting opportunities to further their economic self-sufficiency, and promote greater advocacy and health policy, as we heard earlier in the conference about the importance of how we communicate these messages to policy and stakeholders, both at the state and national level, is so critical, and of course, sustain our global partnerships. So this was one of the billboards that was just very riveting to me when I was in the Democratic Republic of Congo a few years ago. And it just reminds us of the global refugee crisis. This has created an enormous threat to women's health and safety. And it is our moral imperative to create and provide a safe haven for refugees and displaced populations around the world. And not only that, create culturally informed strategies to greater enhance their access to care and their health and well-being free from violence. Thank you so very much.
Good morning, everybody. Thank you for your attention. And as Nancy says, I'm come from Mozambique. I'm here representing JAPIGO. But not only JAPIGO's work. JAPIGO's work is working closely with the Minister of Health, implementing this program since 2010. And I'll be telling the story of this. I think it's a big project. And at the end of, I don't know if I did the right thing, but okay. at the end of this presentation, I hope you can know more about Mozambique and know the steps that JAPIGO have been done on establishing GBV services, and understand the process that have been developed, who's turning in a comprehensive and holistic approach to strengthen health sectors to respond to GBV. Well, Mozambique is an African country in sub-Saharan Africa with almost 30 million people. Most of us are women under 15 years. We are a very young country. We have been independent for 40 years. We are a Portuguese-speaking country. One of the 6 countries speak Portuguese. And the HIV prevalence is among women, it's almost 30.2%, and men have less prevalence of HIV. I think this is some kind of point that shows us what the environment is Mozambique now for women. And women subjected to physical or sexual violence by intimate partner or non-partner during lifetime was 55%. This data from 2012. And 40% of girls marry very early. Unfortunately, Mozambique is one of the top 10 countries with early marriage. And the police background in Mozambique is also young. We have the first national plan to address violence against women in 2008. And 2009, unfortunately, the big movement of civil society came into the first law against violence. And in 2012, we call integrated mechanisms of care of survivors of violence, which is a document who orients all the political movement that should be in place to improve care of survivors of violence, and roll out all the roles and the responsibility, not only for Minister of Health, but for the police, for social affairs, the minister, everybody must do to address this issue. But where we started on providing post-exposure prophylaxis. First of all, JAPIGO has been working with the Minister of Health to provide prevention for healthcare workers who have been exposed to contaminated fluids while they are working with HIV positive or with patients. But this medicine was not only being taken by healthcare workers. At the emergency rooms, survivors of sexual violence were also used this medicine, but with no protocols, with no guidelines, and the sexual violence came to the spotlight with a retrospective study that we have done in the main health facility in Maputo City, which is the capital of Mozambique, and we analyzed 2,400 cases of sexual violence that came into that health facility for 5 years. And the data that shows us that most of survivors were very young, under 14 years. Most of them were students. And the main point of entry was the police. Most of survivors came late for HIV prevention, or even pregnancy, emergency contraception for pregnancy. And we came with the important assumptions to start with this holistic approach that we have to strengthen the health system, create a decentralized and comprehensive services for survivors. There was a urgent need for well, JAPIGO project was focused on, this is what, the development of guidelines, and then the curricular development, implementation on site. At the beginning, we've been implementing in 42 health facilities, covering all provinces across the country. As I said, JPAG is working closely with MOH. We almost link it, and as you know, we have constraints about human resources, about materials, and we have people skilled to do that, and they're working closely with MOH. And the information system, at the beginning, there was no record files. There were no how to know who is coming, what services they are being provided. And in multi-sectorial coordination also, this was one of the most important pieces because to implement those services, it's important to talk to each other, who are on the front line with the police, because as we saw, the police the main point of entry. But the police are not made to be humanized, I can say that, because it's they are dealing with people who are against the law, I can say, but they are not prepared to deal with a survivor. That's why we have to shift that that way of that point of entry from the police to the health care facilities. And the community involvement, this was one of the most important pieces, I can say, and there was not on the policies of the Minister of Health, they won't count it on what community can do, but this in this new plan, many things can happen with community involvement. And finally, the GBV screening on clinical settings that I'll be talk a little bit. This is a study that is being implemented since last year with a validate tool and with the IRB from Johns Hopkins, which is coming with so many answers for our questions. But talking about development of guidelines, in 2011, we start with this manual, which is guiding health managers to implement services. And in 2012, we look closely to those healthcare providers who are at the front line to provide post-exposure prophylaxis for HIV prevention, emergency contraception and STIs, crisis management and trauma management at the front line. This is what we have tried to do, and this is the guide for training and for protocols to provide the services. And in 2012, 2015, we've come with the screening tool, which is being implemented in 2016. And at last, not at least, we keep our eye on children, adolescents, and young girls who have been victimized by sexual violence. This is a clinical guide for also healthcare workers who are at the front line and involved in schools. And the curricular development started from the beginning, training providers, and not only providers, but all those who are on the front line, police officers, psychologists, health managers, for them to come in the same track. And since then, almost 3,000 providers have been trained. In site implementation, as I said, we've been implementing 42 health facilities, but 7 of those, we call them demonstration sites. It's a site that we invest high resources, we invest training, that for them came up with the quality, a place that people can learn and scale up services with quality. And those sites, in these 42 health facilities, since 2011, 5,000, almost 6,000 survivors have reached services. Most of them were female, but there were men also. victims of survivors of sexual violence, and most of them were, as I said, survivors of sexual violence, and very young. Well, Nancy has shown me 2 minutes, but anyway, survivors keep going to the services. Fortunately, as you see, and PEP provision is growing since what we saw in 2010 until now. 80% of survivors who come for sexual violence, they have post-exposure prophylaxis. Here you can see the government of one province recognizing one of those demonstration sites, and this is something that is being political. It's a political movement for equality for survivors, and this is something important. And here I'm showing you like a record. We're trying to do it simple, easy, and cheaper to have data to do more advocacy. Here you see it's we try to make it like a team, a provincial team and district team with all pieces together. They have regular meetings to discuss around the gaps and to discuss the data that we have. And as I say, we involve a community through lay counselors who are doing HIV and testing. As part of this activity, they do also GBV screening for those survivors. And the data shows that 40% of those who said, I am a survivor of violence, were HIV positive. So GBV, experienced GBV, and it's very important to find out on people who are living with HIV. And finally, we start with GBV screening on clinical settings with lay counselors and health providers. And we're trying to spread the message that you can talk to health providers about GBV while you're having your appointment. This is something that is coming and with many answers. And we can find people like Eulalia, for example, who is she's pregnant and she's in INC services, and she's disclosed HIV, GBV, and this is impacting on her health. And the GBV on the military, it's one of the pieces of the project to promote services and screening also on this. There's some lessons learned, but I think the most important is to know where you want to go. You have to know first where you are. And using data for advocacy, this was a very important lesson for us. And finally, saying thank you with the One Picture of Dreams initiative. It's a PEPFAR and Bill and Melinda Gates initiative funded, who are willing to prevent and give services for adolescents and young girls and help them to say, I decide my future. This is what is on the T-shirt. Thank you.
Well, good morning, everyone. And thank you, Dr. Glass and Dean Davidson, for inviting me to be part of the panel. So in the next 15 minutes, or less than, and while my slides come up, I'll be talking to you about healthcare worker perspectives on integrating in a safety decision aid. We've named Dr. Glass has named the MyPlan tool, into primary care settings in order to better support women experiencing intimate partner violence, particularly immigrant Latina women who currently have limited options for support. Okay, so why the focus on Latina women? Although Latinos do not experience higher rates of intimate partner violence compared to other women, they are disproportionately affected by the sequela of IPV. Compared to non-Latino women who have experienced intimate partner violence, Latina women report higher rates of poor physical health and greater psychological distress. There's also data from SWAT and Sabina, which suggests that Latinas have a greater likelihood of being victim to intimate partner homicide compared to other types of homicide. And in the majority of cases of intimate partner homicide, among Latinas, there was a documented history of abuse. So in other words, there was an opportunity for intervention. And when it comes to seeking help or help seeking, researchers have established that Latinas, in particular the immigrant Latinas, recent immigrant Latinas, experience a myriad of barriers when it comes to help seeking, specifically for intimate partner violence, which underscores the importance of routine screening for intimate partner violence whenever she presents to the clinic, because she may be presenting for another issue and experiencing the intimate partner violence. So in thinking about how we in health services could offer linguistically and culturally appropriate interventions geared towards empowering Latinas in decision-making about their safety, like good scientists, we went to the literature to find interventions that have been effective in addressing IPV among Latina women. There is extensive descriptive literature on Latinas and their experiences with intimate partner violence. So surely there was some extensive information on successful interventions. So we looked for studies that described and tested an intervention, had at least 25% sample of Latinas in the study, measured intimate partner violence, and the intervention had a positive outcome on IPV. We did this review in 2015 and looked back as far as 2004. And out of 1,274 studies, we identified 4 that met our inclusion criteria. One of these studies included an exclusive Latina population, and one other study was done in a clinical setting. However, their intervention was not better than the control. So lack of culturally appropriate interventions for Latinas within a healthcare setting was one issue. And then the other issue we identified was healthcare providers. Us healthcare providers continue to miss opportunities to identify and offer support to intimate partner survivors. In our literature review, we found that rates of always or almost always routinely screening for intimate partner violence ranged from 2 to 50%. Now, why is this? Of course, the common barrier is time. Not having enough time in primary care to screen. A lot of providers report having so many other things to already screen for. Lack of protocol was cited as a barrier, so not knowing, 1, the best way to approach, and then 2, in the event that I get an affirmative response, what then am I supposed to do with my patient? So all of these challenges had me thinking about whether or not the MyPlan app developed by Dr. Glass could somehow address some of the challenges of screening in primary care. Is this tool, if the tool were somehow available in primary care, would providers be more likely to screen, knowing that they do have something to offer their patient? And also, would it be something that our immigrant Latinas would find beneficial to them? So here are some screenshots of what the app looks like, thanks to the developer, James Case. And so, of course, safety is a priority. So once the woman decides to download the app, there are some safety features, and this PIN code is part of that safety feature. It's intended to, of course, keep that information private and not even let somebody else know what may be, what the app may entail. The app takes the user through a series of modules intended to help educate her about relationship violence and healthy relationships. The danger assessment is also included in the module, so she can learn about her risk of lethal or near-lethal violence. And then the tool helps the user think about her safety priorities and develops a personalized safety plan for her. So here's a visual of what the user might see upon completing the danger assessment on the app. Dr. Glass and colleagues actually recently published findings from the longitudinal study looking at safety and mental health of women who were randomized to the safety decision aid compared to those who received a controlled website. And women who used the decision aid reported an increase in safety behaviors and were more likely to have left their abuser. So before examining the feasibility and acceptability of this e-tool in primary care settings, we wanted to hear from healthcare workers who serve a predominantly Latina clientele what they thought about the tool and how they thought it could be incorporated into their settings. And so the findings I'm presenting today are from our interviews with providers. And we're currently waiting for IRB approval to start fielding this with approximately 200 women, not a majority of whom we hope will be Latinas, but not excluding other women who may be interested. So we conducted 17 semi-structured individual interviews. All interviews were conducted in English with the exception of one which we did in Spanish. And we asked that all participants have at least 2 years of experience working in primary care and were practicing at least 20 hours a week with direct patient care. So here are some, I don't know how well you can see this, but here are some demographic information about our participants. The majority, of course, were women practicing in community health centers and seeing over 40 patients a week. As you can see, we had a variety of healthcare workers participate, 10 primary care providers, so nurse practitioners, midwives, physicians, and then some registered nurses, social workers, medical assistants, and 1 community health worker. And before delving into the interviews, we asked our participants to answer a few questions about how prepared they felt about helping patients manage intimate partner violence. And so we rated level of, this was not our scale, but the scale rates level of preparation from 1 to 7, 1 being not feeling prepared at all, to 7 feeling very well prepared. And we see that for when it comes to asking appropriate questions about history or current experience of intimate partner violence, or appropriately responding to someone's experience about intimate partner violence, healthcare providers felt fairly well prepared. However, when it comes to assessing their need, assessing their level of danger, or helping them create a safety plan, they felt much less prepared. So our interviews were transcribed verbatim and entered into in vivo for analysis and coding. So this is an overview of who our participants served, and these are words that came from the participants. They described their clientele as being largely uninsured or Medicaid recipients, immigrants primarily from Central America, having low health literacy, and predominantly Spanish-speaking. They also talked about what they thought were some of the other main issues that their clientele faced. Almost everyone mentioned the issue of unstable housing. So one midwife talked about how she was caring for someone who was currently living out of her car. Lots of clients who live sofa to sofa. Many reported that they have poor access to transportation. They also talked about the other healthcare problems that they're dealing with in the clinical setting, so chronic disease and substance abuse. And all providers talked about the need for more mental health services for their clientele. They shared that many of their patients had a history of trauma, either from interpersonal violence or being in abusive relationships, or coming from areas with lots of community violence. So when asked about broaching the topic of intimate partner violence, all participants reported some type of screening, whether they themselves asked the patient at least once a year, or some other member of the healthcare team completed the screening. And then aside from screening, many of the healthcare providers also shared that they come to find out about domestic violence, that it's rarely the presenting problem. So patients come in complaining about feeling anxious, not being able to sleep, and then when further probed, the domestic violence is revealed. Or as we see in this last quote, it comes up in sometimes what would be a routine visit. So a family planning visit, and then the patient discloses that she needs something that her partner would never find out about because she's not allowed to use birth control. But regardless of how it is presenting, the majority of healthcare workers reported that they come across it very frequently, at least once a week. So how are healthcare workers responding to reports of domestic violence? Well, to start, no one had a protocol to guide or inform how they responded. In clinics which were fortunate enough to have full-time social workers, the warm handoff was practiced, So either the patient is taken to the social worker or the social worker is brought to the patient. Another clinic that was developed in part to serve immigrants who have fled violent communities, they do have a program which includes legal support, but even that is not available during all clinic hours. And then there were some clinics that didn't have any support at all, and so their main option was to give the patient a pamphlet and the number for a hotline. So overall, even though women were being screened, many healthcare workers shared that from their perspective, it seemed as though it was just the screening. There was still not much else they felt that they could do for the patient. So for example, one provider shared how she sees a patient almost every year who tells her, yes, she is being abused by her partner. He hits her, and so she just hits him back. And because she hits him back, she didn't want any further assistance. So the provider's like, well, what do I do with that? Getting back to unstable housing, providers also shared that oftentimes clients who are experiencing abuse, they have nowhere to go. No family to go stay with, they can't afford a place on their own, lots of shelters are already full, so now what can we do for them? And then for undocumented women, they don't want to dial 911 or go to some first responder. So again, what are their options? So of course we wanted to hear about what they thought about the tool and how they thought it could be used within their clinical setting. And overall, they loved it. Many shared how they thought the questions were non-judgmental and very useful for helping patients to reflect on their situations and think through a safety plan that would be appropriate for them. Many thought that the greatest benefit of the tool would be helping patients in violent relationships actually realize that they were in a violent and unhealthy relationship, and that there were some options for improving the situation. They also thought that it was something that could be used in a variety of ways, either alone or with a social worker or a community health worker. But given the issue of low literacy with so many patients, they thought that it would be best if it were something that were used along with a healthcare professional. So our next steps, as I mentioned, are to field the e-tool with patients and get an idea of what modifications we may need to make so that it is suitable for in-clinic use, as well as perhaps some modifications for a lower literacy population. One of the main issues, however, one of our partner clinics keeps raising is if the tool is offered through a clinic-supported system, so for example, my portal through the EMR, whether or not that information should be automatically available to the provider or whether it should remain private with the patient. And if the patient does know that the provider is going to automatically see their responses, how honest might they be? So we do not suggest in any way that my plan is something to replace any of the current clinical services, or that in and of itself it is the silver bullet for IPV management and secondary prevention, but we do think that it has a lot of promise for empowering women who are currently in abusive relationships. And so we're excited about our next steps to hear from our patients what they think about the tool. Stop there.
So our panel did an amazing job, and we have time for questions. And so I want to ask the panel to pick up the microphone you have in front of you. And there are microphones, so please feel welcome to come. Please introduce yourself.
Sarah Michelle, Baylor College of Medicine in Houston, Texas. We have a large refugee population as well, and Krista, I was wondering if you're trying to repeat or recreate the program in other states.
Oh, that's a great question. We have been approached by a number of colleagues in Denver, in Utah, in Georgia. I'm part of the North American Refugee Healthcare Conference, and every year I play an important role in presenting on our outcomes and what we're doing. And yes, there is definitely interest, and there are programs that are beginning to do so, such as in Philadelphia, and they're one of the partners on the grant that we are pursuing with Dr. Glass, where they do have similar models unique to their city and their refugee context locally that are incorporating greater training and education of providers, but also the important need to partner with the community directly, especially in meeting some of the language needs. But there are still many ways that we need to bolster this. I think one of the things that providers struggle with is the fact that because of the constraints on the time and the limited opportunity to really delve into some of the broader social service needs, the major missing gap is the fact that you need to bring on extended support through working with social work, working with the VOLAGs, which are the Volunteer Refugee Resettlement Agencies that are housing the patients in the community, getting the kids into school, providing job training. And so that comprehensive, broad lens view is what is so critical to make sure that you're not providing just your clinical care within your specific field or discipline, but that you're engaging a cross-sector of professions and agencies that are able to serve the refugees in a myriad of different ways beyond just the scope of your limited practice and field. And I think that's what's critical and that's necessary to be able to replicate this model in other states and also find important ways to pay for this. That's another challenge, finding ways to get this paid for, because it's not enough just to have an interpreter, because you really need to make sure you understand the cultural context, the historical context, the trust that you need to build is beyond just what you can articulate by words, and having that broader lens to make sure you're bringing these interdisciplinary stakeholders to the table to help inform best practices to comprehensively address the needs of women. And I think that's the approach that we've taken that has shown success. And we have partnered with the local health plans, insurance plans, that we're hoping to create greater models of paying for this through partnership with our Medicaid health plans to pay for that care coordination and case management with the cultural health navigation.
Thank you.
Please, yes.
All right. Thank you very much, the speakers. But my question is for Krista. I work in Nigeria. My name is Amara Frances Chisoba. I work with Center for Clinical Care and Clinical Research in Nigeria, and I'm a nurse. So we see these women that went through intimate partner violence and gender-based violence sneak into the hospitals to get access to care, mainly just for their health, maybe because of the scars or maybe because of rape. But when you engage them, they don't want to report to the police. So you actually pointed out there are reasons, threats, for instance, that make them don't want to come out to speak up about this. So I found that challenging because I believe there are more of them out there that don't even want to come out at all. So I had to start up a platform I call Chat Room. I had to paste numbers where there are women gathering, hospitals, schools, so they could call me up and let's talk, and that could be the basis for me to lead them to where they need to get services. So you said you were able to get to provide services for up to 5,000 clients. So I want to know what you did. What was the magic? How you got them to come out of their shelves to come to your clinic? I want to do that, please. Thank you very much.
Thank you. So that is a profoundly important question. I'm so glad that you raised it. And I cannot emphasize it enough, the importance of building trust and also making sure that your team comprises personnel and staff who represent the cultures that you're trying to reach. Honestly, hands down, that is at the fundamental element, the most important reason why we've been so successful, because these women, you saw pictured my entire staff, they represent the various communities that are the most vulnerable, that are not going to seek out care, but they are not just confined to the hospital. They're in their homes, they're in their apartment complexes, they're at their churches and mosques, they are at the community meetings. So they are deeply entrenched within their communities. So they are a trusted figure. And trust is absolutely critical because they're able to build those relationships outside of the confines of the medical center or the hospital, so that they have somebody that they can go to as almost like a neighbor, as a friend, as a mentor, to say, hey, I'm having some issues, or they themselves can begin to delve into the more sensitive taboo issues around violence and around genital cutting, which is extremely taboo. And they're able to, with those relationships, then bring them into care. And also, when they arrive for care, they're there as well. So you have this face that you're comfortable with, that you know from the community, who is now your partner, helping you navigate the healthcare system, helping you sign the forms that are hard to understand, helping you navigate how to get to the pharmacy, how to get to social services, how to get to the behavioral health provider. And of course, there are ways that we need to bolster that further so that we don't have, we can provide services all in-house so that we don't refer them to another practice where they don't know the staff, they're unfamiliar with the environment, so that we could bring that all under one roof so that the same navigator can accompany them and provide not only the interpretation, but the other elements of care coordination to ensure follow-up and to ensure ongoing trust, and also be that important liaison to the provider and the rest of the team. So I can't emphasize that enough. Thank you.
Anna, would you like to add, or anybody else want to add to that? How do you engage women to tell their stories?
No, I would echo the same comment that it does come down to trust, people feeling that you are truly invested in them, and that they can trust you with the information that they're going to share with you, and that you're going to actually help them.
Can I, over here, please? I'm sorry.
No problem. Brad Dreyfus, University of Arizona College of Medicine, Emergency Medicine, and also Public Health. So my comment and question are directed to Dr. Glass and the entire panel, and it comes from the perspective of someone who cares for patients on a daily basis, where this is in our face, whether it be community members or whether it be our students in the rape culture. It makes me really want to ask our community how we start focusing on upstream. How do we really start addressing the concept of toxic masculinity, which is defined by the narrow and repressive description of manhood, designating manhood as defined by violence, sex, status, and aggression. And not just addressing it and helping our communities understand what it is, but creating the interventions and measuring the effects of this social cultural underpinning. Thank you.
Thanks, Brad. Lori, I'm going to let you respond to that, given your work in the prevention.
Well, I actually think, this is one of those areas where I think there's probably more experience in the global south than in the global north. There's huge networks now, Men Engage and others, that are working at community levels just around these types of issues of looking at the rigidity of gender-related norms and practices and how to transform that. And I think that many of the primary prevention programs that we see being successful actually do take on board some of the issues that you're talking about. My experience is that you need to actually work with men and women and the community writ large, because it's very difficult if you're only working with one part of that equation, right, for that person to adopt new practices that are going to be counter-normative. And there's a lot of work also being done, I think, in how do we both measure transformation of norms, and we talk about it a lot, but how can we actually measure it better so that we know if we're on the right track. And so, I mean, we could speak afterwards, but you know, I think you've touched on a very important issue that is very much on the forefront of the work that's being done in terms of prevention as opposed to the service kind of work that my colleagues are doing.
Thanks. I'm going to go over here.
Real quick, as a follow-up, I think
Oh.
for the record, I think it's fair to say that whether it's emergency physicians or providers in general, we don't feel like we have the language, the tools, the comfort of dealing with these complex issues, whether it be death and dying or whether it be issues of violence. And thank you.
Thank you. Very good point.
Okay, thank you. Thank you to the panel. My name is Kristen Schneider. I'm at Penn State University in the Department of Public Health Sciences. I think this question is mainly for Dr. Heisey. I'm very interested in the end of your I'm very interested in the end of your presentation, the whole presentation, but specifically the end related to labor engagement in the workforce for women and how that can potentially be a prevention, but also a risk factor, and wanted to hear a little bit more about that research, please.
Well, basically what that research was looking at is taking demographic and health surveys and other population-based survey data and looking across many countries. So there's now like 80 some odd countries, right? And so it allows us to go in and start to look at not only individual level risk factors, right, but how those interact with larger structural risk factors. And in terms of the employment thing, I mean, I think, again, if you look across setting, it's always been very confusing because in some places it seems to increase risk, in some places it decreases risk, and people couldn't get a handle on it. But I think it's because it's an interaction of forces, right? So it's not always the same. The role that employment plays in terms of risk depends on what's happening in that relationship. For example, is the partner employed or not employed? It depends on what is happening in that context. Are many women employed in the context in which this woman is entering employment? It has to do with, you know, the interaction of norms around gender and employment. And I think the reason we haven't been able to get our minds around it is because we haven't been dealing with the dynamism of it all. And I think that's sort of what we're trying to unpick now. I mean, I think the big message is short term it can be a risk factor in settings where it's non-normative, but it's almost it's not something that we should retreat from, because social change always happens on the backs of brave people, right? It's sort of something that we need to move through, and in terms of what we can do in terms of programming is help people recognize that these are part of the dynamics and help prepare for them in the design of our programs.
I'm going to come back to the middle here.
Yes. Thank you. Mark Miller from Fogarty, NIH. Thank you to all the speakers. One of the issues about health is it's usually a secondary effect to many other issues in life. And the big elephant in the room, which was not discussed at all, was women's rights overall in the political process and suffrage in many of these countries. And I was wondering whether or not any of your work is linked to the political process of women's rights and voting. Some of you were commenting about the fact that children are getting married at the age of 15, which of course then prohibits them from ever getting an education and becoming part of the more established political process. So I'm wondering whether or not any of your work is related to the big elephant in the room, which is basically women's rights through voting and suffrage.
That's true, and I think in Mozambique, for example, there is a huge movement around this topic. Now we have a new administration, and there is a lot of work that has been done on that, but I think there is still a huge gap. Early marriage is almost in the law because in Mozambique, unfortunately, girls with 16 years old, they can be married when the parents allow it. And this is something that we keep fighting to address this violation of human rights. And there is a long way, but I think we are on the track. We have a new law. This is so recent, and the civil society is engaged on doing more for that. Now, violence against women is not more in the families. It's something that is being discussed every day. For example, a woman very famous, I can say, she was the older daughter of the former president who was been killed by her partner inside home, gunshot. And this is coming like a huge movement around this topic, but we should do more.
Any other response to that? Great. Okay, back. Sorry, where are we now? Over here. We have Judy.
Judy Wasserheit, University of Washington. First of all, thank you all for a wonderful panel on a tremendously important topic. I have two questions. The first is for Carmen, and it is somewhat specific, and that is that when you talked about your systematic review, I was surprised that you only looked at positive studies with positive effects. There's a fair literature that suggests that it's not only important to look at negative studies, but also flat studies where there's no significant positive or negative effect. So I'd be interested in why you decided to do that. And then the second question is to anybody, but it is a more general question, and it builds on some of the other questions, which is, we've traditionally talked about pairing clinical interventions with, on the prevention side, interventions that really promote education and access to jobs for women in some of these areas. And I think more and more we're coming to understand with that ecological model that education and jobs for men are also important. Gets back to some of these earlier things. Are there any studies looking at joint interventions that jointly try to promote education and job access for men and women in these relationships?
Carmen, you want to respond?
Sure, I'll start first. Thank you very much for the question, and yes, you're right. And we have looked at the broader literature, but specific for that paper, we were looking at elements of effective interventions among Latina women, and so that's why we went with the studies that had the positive results. Thank you.
So programming that engages.
So one thing I am aware of is actually we're working on a design of a program right now for Liberia, which is sort of focused around that idea of partners, couples, and working around economic empowerment for both of them, and also looking at sort of what we've seen is that two things happen. One of two things happen when you have these huge economic dislocations where men are no longer able to provide. And it's such a fundamental, the notion of male provision in most of these settings is so profound that either the women sort of step up to the plate and they just take over and men retreat, or they become very threatened and you have this compensatory type behavior where they're exerting control in the one area where they feel like they still have some control, and that's the family. And so I do think that the problems that men are facing and able to provide for their family is a big part of the dynamic that's driving some of this all over the world. And how the challenge is, how do you both help address that, but also in the way that you do it, shift more towards less rigid divisions of labor that says, actually, we are our partners, and we will both try to provide for the family. And, so for example, I'm doing a trial right now in Rwanda, and there they just passed a law, which is very interesting, where they've changed the headship. So by law, men were heads of the family, and a lot of the authority of men in settings falls from that notion of headship. And so we're trying to integrate that shift in discussions all around that shift of what does it mean now that both men and women are heads of are partners in the headship of the family. What does that mean, and how do we feel about it, and blah, 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 into the intervention. So I think we need to be doing more of that, and I think we need to think quite carefully about how we do it so that we don't sort of reify the idea that men should be the only one providing, because quite frankly, as we know in the US or everywhere around the world, economics just doesn't allow for single family economic support any longer, and we need to help create new models.
Come back here in the middle.
Hi, my name is Chen Lei, a PhD candidate from Johns Hopkins School of Nursing. So I do believe the research in address IPV issue is of great value and importance. So I was just wondering, from your experience, our distinguished panel, so what is the biggest challenge when you are doing this IPV study? Maybe you've already answered it partially, but I still look forward your responses, very short responses. Thank you.
So, biggest challenges right now as we move forward. Krista, you look pensive there. Carmen, you start. There you go.
I think from the health services perspective, it is the challenge of time. I think EMR rocked everybody's world. And so how do we now work more effectively within our teams to deliver care in a more effective way, which would then include addressing a number of the other issues that are impacting people's health.
Great.
I think for me, I would echo what I mentioned earlier. The biggest challenge is, one, providers not knowing, as the person who asked the question on my left, not knowing where to start, not knowing how to even engage in the discussion, not knowing how to build trust. Because as we know, there's extraordinary shame and stigma both within families and within the communities, and a disincentive to even seek help. And so I think that's one of probably the biggest challenges, is just understanding how to bridge that gap. And as I said before, it really is anchored in building trust and making sure you have culturally competent providers who can begin to engage women and families in a meaningful way. And I guess another plug on a more political side, right now we have the biggest threat to serving this population is the current political climate and the anti-refugee, anti-immigrant rhetoric, which is completely goes against our efforts on the ground to really reach these communities and be able to make sure that we can welcome these families and extremely vulnerable populations to the United States and other countries, and really provide the infrastructure needed to support their care and economic self-sufficiency. I mean, I think that's one of the larger political challenges that we currently face right now, is that threat to serving the most vulnerable populations affected by the global refugee crisis.
Great.
Well, shortly, I would say, on my view, my point of view, the main challenge that we are facing recently on GBV screening study is to address the beliefs of the healthcare providers about violence while they are providing services. This is one of the most challenge, and how we can do an effective training to not only to show them how they can do the service delivery, but how can they behave. This is something that's very important.
Lori, do you have any?
Well, just real quickly in terms of primary prevention, what I'd say is I think the last decade has been one of generating evidence, and I think we actually have learned quite a bit about what works, but it's not translating into programming. And so one of the things that I'm personally trying to take on board is how do we do that translational work? And it takes a lot more than just writing it as a policy brief. People don't know how to actually program in this new area. And so that's some of the work that I want to try to take on board.
I am so sorry, but I'm going to have to make that the last question. I know we have people waiting, and I apologize. Our panel will be here. You can ask them questions. But I'd like to really thank, what a powerhouse group of women. Thank you so much for your time.